Hey, good morning, everybody. Some of you will know me. My name is Mary Tilki, and I've been chair of Irish in Britain for a number of years. I'm not chair anymore, but I'm still involved with this healthy aging, this positive aging project. My background is in nursing and in nursing education, and I've done a lot of work around health inequalities, particularly health inequalities in older people. And my doctoral research was on the health of Irish people in Britain. I was passionate about the needs of older people long before I actually fitted into that cohort myself, and even more passionate about the needs of the Irish community and the needs of other ethnic minority communities. So I was delighted to be asked to be involved in the Healthy Aging project for Irish in Britain. Some of you may be asking why we need a healthy aging project or a positive aging project targeted at the Irish community. And the simple reason is that the Irish community is in Britain is older than has an older age profile than the population as a whole, and it's significantly older than the vast majority of other minority ethnic groups. Now, you may be wondering why I'm saying ethnic minority group, because when this term is used, it generally conjures up images of people with dark skin and people who don't speak English as a first language, possibly people from Africa, people from Asia, or Caribbean countries. And therein lies the problem, because the Irish people are predominantly white-skinned and English-speaking. The man in the street and the people who make policy tend to use skin color definitions of ethnicity, so the Irish are excluded. And this means that the data, although data is collected on the Irish community, and those of you who've completed the 2021 census will have ticked various boxes about ethnicity, the data is collected on where they were born, how people identify, and what passport they speak. When the census is analysed by UK policymakers, they tend to put the Irish in the overall white category. So they become invisible because of that. And for that reason, Irish in Britain have worked with Nottingham University to analyse the data separately on the Irish community. And although we have an awful lot in common with our British peers, you will know yourselves that Irish people have their own culture, heritage, and customs. And our experience is one of migration. So we have got more in common with other migrant groups and with people who look like us. And this is particularly important for older Irish people who have had many negative experiences during their stay in the UK. Now, the analysis shows that the numbers of Irish people in Britain, the number of Irish people born in Ireland who live in Britain, have gone down since the last census in 2011. And this is due to death, return to Ireland, and possibly people who identify differently. The number of gypsies and Irish travellers have actually increased in that time. But country of birth data, where you were born, is quite a simplistic way of looking at Irishness, or indeed any other ethnicity, because with Irish people, so many people who were born to Irish parents and grandparents identify as Irish. And the number of people with Irish passports has increased, particularly since Brexit. And they're obviously from Irish parents or grandparents. And there are regional variations as well, with the largest populations of Irish people in London, the West Midlands, and the northwest of England. And there's another group which we mustn't forget is many Irish people, many women like myself, who married or who were in relationships with non-Irish people. Uh, and our children may or may not identify with Irish, or they may identify with Irish and the other aspect of their ethnicity. So why do we need to look at the health of the Irish community? If we can have a look at the next slide, Ellen, please. So what's different? Why do we need to look at the Irish population? The analysis done by Nottingham University, funded by Irish in Britain, shows that a greater proportion of the Irish population in Britain is over 50. And that varies, as I said, by region. Very high numbers in London, the West Midlands and North East England. But sadly, only 41% of those people actually rated their health as good or very good. And gypsies and Irish travellers have got the highest levels of poor health. And that happens much earlier in life. It can be seen right the way through the life course. The census also shows us that Irish people have got higher disability rates than the majority population. The majority population have got a disability rate of about 17.5%, whereas it's quite different. Irish women, it's more like 24% who are disabled, and in men, it's just over 20%. So it's quite a bit higher. But gypsies and Irish travellers are much higher even than Irish people. So about 10 or about near enough 10% for both men and women. Not surprisingly, then, we've got high levels of unpaid care. It's very similar to the majority population. And this is, as you would expect, mostly women. Irish people are also more likely to be homeowners, but they're far more likely to live alone. And that has got implications for their health as they get older. The reason they own their own home is some of it is to do with the fact that they had great difficulty getting public accommodation in their time. And there are significant numbers of older Irish people living in the private rented sector, which is one of the worst sectors to live in, particularly as you get older. And gypsies and Irish travellers have got real problems. 40% of them living in social rented accommodation, and they're far more likely to be overcrowded as a result of that. So next slide, please. So the invisibility of the Irish, because of the way in which the ethnicity is defined, means that there's a lack of recent research. There's a lot of old research, which shows that the Irish community in Britain have got high levels of hypertension, stroke, heart and respiratory disease. We've got some of the highest levels of cancer in the community. And there are also disabling things like musculoskeletal disorders, rheumatism, osteoarthritis, and things like that. And that fits very much with the anecdotal evidence that we get from our Irish organisations. When people approach them for help, they're often experiencing problems with either having these conditions or getting help for them. Conversely, recent research done by NHS Digital in 2021 shows that Irish people make good use of mental health, learning disability, and autism services. Some of that is positive, but some of it, the fact that people need that kind of help, is actually quite negative. But it is slightly reassuring that they're actually using the services that are available. There is also slightly higher use of mental health inpatient admission. So people are still being admitted to inpatient hospitals. And they're also users of services like CBT, cognitive behavioral therapy, and IAPT, which is improving access to psychological therapies. Now, the NHS Digital actually measured the people who were attending these services or being admitted to these services. What it doesn't do and what it can't do for anybody is actually identify who is not accessing those services. The information also shows high rates of depression amongst older Irish people, and that is often alcohol related. And I think this is not to stereotype the Irish, although some of that may be going on. I think what may be happening, and I'm speculating a little bit here, is that Irish people who are depressed may use alcohol to alleviate some of their symptoms. And sadly, older age suicides are increasing for all communities, but they're especially so amongst the Irish. And this is some of the work that has been done on the relationship between alcohol or substance abuse and suicide. The link is made. There is very clearly a link between alcohol or substance use and suicide, but the link doesn't seem to be made for the Irish community. So I wouldn't want to stereotype anybody, but I think it's an important issue to bear in mind. So next slide, please. Right. What is health? Well, some of you may well remember this. I had it drummed into me as a student nurse many, many years ago. But this was the way in which the World Health Organization in 1950 defined health as a state of complete physical, psychological, and social well-being, not merely the absence of disease and infirmity. And that was probably quite right for it was probably quite right for 1950 after a world war, the Second World War, where the main problems were infectious diseases and life expectancy was quite low. On average, men lived around until they were 66 and women lived until they were 72. But that definition is a kind of a static one. It doesn't change. It doesn't account for everyday illness that people suffer. So you can have cold or a flu or something like that, not feel great one day, but still be healthy. It doesn't take account of anybody's personal circumstances. It doesn't explain why a person with one disease may recover quite well from it, but another doesn't. And we are never, I suppose, looking at it now, many years afterwards, who is free of disease and infirmity? So what has happened? Next slide, please. Demography has changed. The position of people in society has changed. People are living much longer. The average life expectancy in Britain today, and if you look at it today, you'll find a different one tomorrow. But on average, men live until they're 78.8 years, and women live until they're 82.8, which is, a good 15 to 18 years more than they did when the World Health Organization defined health. People live with disability and diseases now which they would not have survived back in the 1950s. Inevitably, age does affect health, no matter how well it does have some impact on health. So we're always exposed to usual illnesses. We have accidents, there's stress, so nobody can ever be completely healthy. It's a very dynamic thing. So it's moving and changing. So this isn't a definition of health. This is more like a concept of health or positive health, as Machteld Huber and her team called it. It's based on the ability to cope and to be resilient and to maintain a balance in your life and the ability to self-manage the stress and trauma that we're all exposed to from time to time. It's about resilience. Resilience is a word that comes up time and time again, and I think it's important for our community. But it's about the way in which we adjust or bounce back after illness or disability or some kind of stress or trauma. And I will talk a bit more about resilience in a minute. This concept of health also emphasizes what we can do and who can help us and what can help us, rather than focusing on what we can't do as individuals to maintain our health. And it's very much about a person-centered approach to promoting healthy behavior and functioning. Everybody is different and everybody's circumstances are different. So we all know what, we should be doing to engage in healthy behavior. But we're all exposed to different barriers to doing that, which ultimately affect our functioning as healthy people. And this concept of health recognizes three domains: the physical, the psychological, and the social. The physical is about the ability of the body to maintain equilibrium and balance. So when you do get ill, it's about the ability of the body to heal itself. The psychological is really important as well. So it's about, if you have an illness or a disability, it's about understanding that, being able to manage it, and finding meaning in it. Because, you might think that getting a diagnosis of cancer is really devastating, and it is. But it also can add meaning to people's lives as they put life in perspective and actually think what's good about it. And the social aspect of positive health is about being able to live an active life, to go to work, to enjoy social activity, and to feel healthy. So it's a very big concept, but it's more embracing. It's pertinent to everybody in society, but I think it's completely pertinent to people who are older. So can we move on to the next slide, please? Now, I've mentioned resilience earlier, and I'd be the first one to say that the Irish community in Britain are a resilient community. They've bounced back and continue to bounce back over the years from all kinds of stresses and traumas. But I think at an individual level, not everybody is as resilient as they might be. And if you have low resilience, the ability to bounce back from things, if it's low, it increases the risk of frailty and general decline. I will talk a bit more about frailty shortly. And it depends on social, economic, and individual factors and physical health. It may depend on where you live. It depends on your income, how economically well off you are. And it depends a lot on individual factors as well. Some people are very positive and outgoing and others are less so. And of course, it does depend on physical health. A major illness will be more difficult to bounce back from than a simple one. But resilience relies on a positive sense of self. It's about thinking about your own worth. It's about valuing what your own strengths are, your resilience and your abilities. Because it's really important to feel in control, to know how to cope, and more than anything else, how to get help. And I think that is an issue that we maybe need to be able to reach out to people a bit more. And what is important, and I think it's an important aspect for our community organisations, is social belonging increases resilience. Obviously, family is really important, but not everybody has family or family who can support them. Community is really important. Church, either for its religious aspects or its social aspects, they all make a difference and give people a sense of belonging, which can make them more resilient. But it's not just about what you can get from others, it's about what you can give to others as well. So you can be more resilient if you're able to help others, even if it's in a very limited way. Having a purpose, feeling valued, but supporting others and feeling supported by them. And that's again a strength of our organizations. It's about personal growth and learning new skills, meeting new people and experience that's actually telling you that you're still a worthwhile person. And again, volunteering is great for our community. We have armies of volunteers supporting our community in the various organizations, and that's great for us as a community. But it's also really good for our self-esteem, for our resilience, not to mention for society. And I've seen so many positive changes to people once they start volunteering over the years. Next slide, please, Ellen. So, moving on from the work of Machteld and her Huber and her team, in the mid from about 2010 onwards, the World Health Organization began to talk more about positive health, and they have developed they developed a positive aging strategy, which builds that in, and that has recently been adopted. If you look at the last point on the slide there, the CMO report by Professor Chris Whitty. It's a UK report. It's about health in an aging society. And that report summarizes the main points of positive aging there. And I think it picks out some of the things that are really important to the Irish community, some of which we're doing already, but it's worth just going over. So positive aging aims to improve quality of life and not just to lengthen it. And I think that's really important. And the aim is to do that by helping people to maintain their independence, by reducing disease and adapting the environment to actually help people who are ill or who have become disabled, whether it's through old age or accidents. Positive aging is about delaying ill health and disability, because people are living longer, although it's slowed down a little bit recently. People are generally living longer, but they're spending longer in poor health in the later years of their life. So the aim is to actually slow that process down so that people live longer years, but in better health. And the other aim is to reduce multimorbidity. Sorry, go back. Yeah, to reduce multimorbidity. Multimorbidity is having a number of different illnesses or conditions. Having one condition is bad enough. Having three conditions means you're 3 times worse. Well, it doesn't. It actually means you probably could be 4 times worse, because having a different number of conditions, they interact with each other and multiply the effects they have on the body, on the mind, and on, the family and economy and things like that. Frailty is really important, and I'll come back to that in a minute. It overlaps with, but it's different from multimorbidity. We'll talk about that. And, a lot of effort is being made now to adapt the environment to improve independence and quality of life. So it might be about helping people to adapt their homes so they can get about their homes more. It may be making our organizations more accessible to people who have got particular disabilities. It may be simple things like having more toilets, having more buses that have got wheelchair ramps and things like that. And I think one thing we mustn't forget about, particularly given the high levels of mental ill health in our community, is that mental health needs are critical part of maintaining a positive health in old age. Depression and dementia are rising. Some of that is due, some of the dementia is due to the aging of the population, but the depression and the dementia that's often associated with depression are due to many other things in society rather than just the aging process. And I think one thing which the CMO report in 2023 highlights, and I think it's a really important one, is that better quality of life requires less medicine and not more medicine. So I think there's a sound economic argument for that. So next slide. This is not me going all philosophical at the moment. But I think it's important to point out that positive aging applies to everybody, not just older people and not just the Irish. But within our community and within society in general, there's a tendency to focus on physical function and the social interactions which improve quality of life. That's necessarily so. But quality of life depends on life having meaning and understanding what's wrong, what's going wrong, what's gone wrong. But for older people in particular, to be able to manage life's events, we're all getting older. I'm certainly getting older. But for the most part, I feel able to cope with the changes that are happening. Because quality of life is about being able to carry out our daily activities and to participate in family and community life as much as possible. Maybe with help and support and resources to do that, but we should still be able to do that in order to maintain quality of life. And this is when people have purpose in life, when they have meaning and opportunities for personal growth, there is a lower risk of dementia. That's very recent research from a large study in the United States. And I'm sure those of you working in Irish organisations will actually be able to vouch for that as well. So next slide. So how do we go about this? Irish organisations are actually doing a lot of this already. I think there may be opportunities to not to speed it up a bit, but to actually make it a bit more dynamic. The evidence through the research shows that 80% of chronic disease is preventable, but prevention is very poorly funded. And I'm not sure the new government is actually taking that into consideration as much as we had hoped. Our member organisations do a great job, and they vary. They do different things in different places, but they offer physical, mental, social health activities and well-being, mainly to meet the local needs of their community, or very sadly, to meet the demands of funders, whatever funders will pay for. And the research that was done by Ellen a couple of years ago shows that Irish people value social engagement. They really value their Irish identity and their culture. They made that very clear in the research that was done only 2 or 3 years ago. And I think, and this is not a judgment, it's a suggestion to people. I think perhaps there might be more opportunities to capture Irish culture, dance, language, sport and art and things like that to improve health. I know in my locality, I could go to a Zumba class every day of the week. I could go and learn Italian. I could learn Greek in my locality. In fact, in my locality as well, there is walking football, and these are fine. These are absolutely great. But I kind of have a pipe dream in a way that why can't we have an over 50s Irish dance group? Birmingham have got a wonderful Cúpla Focal Irish language course. Not a course, an activity. There's quite a bit of walking football around. Maybe the GAA can do something around walking Gaelic football. And of course, art and poetry and yeah, literature and things like that. I think in some cases there may be more scope to work with local statutory agencies as well. They might be local councils, but things like the Office for Health Improvement and the UK Health Security Agency, they're always running various health campaigns, which maybe Irish organisations could host. Um, or make sure that, we've got input into them. We don't need to reinvent the wheel. I'm very clear about that. But I think it's important that we make links. We use the expertise of the local NHS, major charities like Alzheimer's, Age UK, Mind, various public health departments, and they'll be glad of the opportunity to do that. Various professionals as well. We've got a large number of retired professionals in our community. And we've also got a large number of people who could be experts by experience, who have experienced various health problems and healthcare systems. So there's a lot that can be done. And I think there's quite a lot that needs to be done given the pattern of poor health within our community. So moving on. I don't want to, I don't want to teach my granny to suck eggs, but we know that at least during COVID, there was a slow uptake of COVID vaccinations. And as we get older, we're at increased risk of various infections. Many in our community have chronic respiratory and heart disease. So getting something like flu or just a very bad cold or something like that can be very devastating for people. So I think we need to promote the uptake of flu vaccine in particular. And I think things have improved a little bit with COVID, but my own experience within the Irish community recently is people say, oh, I've had 4 COVID vaccinations, I'm not having any more. So I think we probably need to push those as well. We don't need to do it. We need to work with the UK Health Security Agency and local bodies to do that. Shingles is very important for older people. It is really very distressing, very painful for older people. So where possible, people should be getting that. The pneumococcus vaccination aged at 65 will help prevent sepsis and pneumonia. It's quite important. And there has been a recent push on vaccination for the RSV, the respiratory syncytial virus. So, I think we need to be encouraging people to take those because they're important in preventing deterioration in health. Next slide. Screening for cancer is really important, despite, the lack of very recent update evidence. Our anecdotal evidence from organisations is still telling us that Irish people are they're suffering from a lot of cancer. They're presenting late, and the late diagnosis of cancer means the mortality is higher and the treatment is often far more invasive. So we do need to be pushing people for screening, and that'll be around breast cancer, cervical cancer, and bowel cancer in particular. And the older members of our community, maybe not the younger members so much, the older members of our community are very embarrassed to talk about boobs and cervical smears and prostates and bowels and things like that, but really important. And they have made a great difference. The availability of screening has made a great difference to mortality from cancer. I think the NHS long health check for smokers and former smokers is really important, and one that generally easy accessible, often in places like supermarkets or town centres. And men are really bad at getting prostate cancer checks, so they've got to go. That's got to be encouraged. And I think as community organisations, we can do that by engaging with Breast Cancer Awareness Month, maybe putting on an event in our organisation. Maybe if we've got premises where we could host the long health check, maybe publicising Movember, which is actually about prostate cancer. I'm not a public health specialist, but I think there are opportunities, and there's a great need in the community to do that. So next slide, please. And of course, the other thing is, our general health surveillance that the GP in general offers, or local community health. The NHS health check. I think we really should be encouraging people to have that every 5 years. There is also all GP practices have to adopt the long-term condition strategy. Our community, like many other communities, have got many different long-term conditions, which are managed mainly by GPs, maybe in liaison with consultants, and the services are often run by specialist nurses. Some of you will be familiar with the asthma nurse or the diabetes nurse, or they may be a musculoskeletal person, maybe musculoskeletal physio rather than a person. And I think they're often far more accessible, and people are happier with them. I've heard people say to me, I couldn't see the doctor, I only saw a nurse. But in my own experience, the nurse with the specialist knowledge is often far better informed and more realistic about the care that somebody with a long-term condition needs. And I think, just very simply, we should be our GPs should be doing this, and we should be reminding them if they don't do it, for blood pressure checks, to have reviews of medication. The practice that I attend have got a very good pharmacist who rings on a regular basis to review medication. People who have got diabetes or pre-diabetes are entitled to eye screening, and that's really important. And things like dental, eye, and hearing checks. Dentists are very hard to find, but people should be encouraged to have dental checkups. Get their eyes tested regularly. Irish people, and indeed many older people, can be very embarrassed about having hearing checks. They tell you they're not deaf, they can't hear anything, and then when they get hearing aids, they don't wear them. Visual problems and hearing problems are significant risk factors for dementia, so people should be encouraged to get them. And men over 65 should be encouraged to go for their AAA screening. It's an aortic abdominal aneurysm screening. It's just a very simple screening of the belly to identify bulges in the aorta, which can burst suddenly. So these are just everyday, ordinary things that we should be encouraging people to avail of. They're out there. You may have to root around a little bit for some of them, but they're there for everybody. Next slide, please. And as I've said, many Irish people have got not just one long-term condition, they have more than one. And these may be physical conditions or mental conditions or a combination of both. But the problem is they interact with each other. They increase pain, stress, discomfort, or disability, and they can knock people's motivation. They can really make a big difference. Sadly, the NHS tends to deal with single conditions, and this is why going back to the GP practice to have those managed is really important, because they coordinate the services. I wish I could tell you that GP practices were easy to access, but we shouldn't avoid trying to access them. Many GPs have got a specialist interest. In some practices, you might find a gypsy who deals with skeletal disorders. Somebody else may have a particular interest in heart disease. There may be They may be a skin specialist, a range of specialists, but there are also advanced or specialist nurses and therapists who are really good. But we should also be working with organisations like the British Heart Foundation, Stroke Association, the Asthma and Lung UK. They're brilliant charities that actually provide advice, self-help group, things like online exercise classes, or there might be face-to-face classes in a local area. I saw a very interesting exercise class from British Heart Foundation last week online, so we should be encouraging people to use those. Next slide, please. Social isolation. I'm preaching to the converted, I'm sure. Irish people are more likely to be socially isolated, living alone with long-term conditions, either widowed or maybe people who have never married. And then when you're in poor health and you live in an area where the bus provision or where the transport provision is poor, or you're afraid to go out because of crime or fear of crime, all these things contribute to social isolation. And in old age, depression and anxiety are common, but they're not necessarily well recognized by doctors or treated by GPs. It's almost as though, well, what do you expect at your age? So again, our Irish community provides so much support for people who would be socially isolated. And I'm just wondering whether this social interaction that's on offer could be more preventive. Could we use music more to actually stimulate people who maybe have memory problems or developing memory problems? Singing is very good for memory, for speech, but it's also very good for people who have respiratory problems. Creative writing might be used, encouraging people to tell stories that maybe they've suppressed, or just to show off their writing skills. Painting, art in any form, or outdoor activities. I think we probably, there are restrictions on that, the weather just being one restriction. But if people could get out, it probably would be far better if they could do that occasionally. And we should be making more use of social prescribing. GPs can prescribe social activities to prevent isolation, to improve physical or mental health, maybe sending somebody to a dance class or swimming or doing something like that. And our organisations maybe should be making connections with social prescribers. The GP practices will employ somebody, a social prescriber, a link worker, getting in touch with those and saying, we offer this. We may not be able just to offer it to the Irish community, but it could be worth, if it's based in an Irish centre, it will still have predominantly an Irish participation. And cultural identity is really valued, so activities and interventions should make more use of Irish music and sport and things like that where possible. But we shouldn't forget that people, the older generation, it's not just Irish music for them, it's not just Irish sport. There has to be a variety there, but particularly for the older element of the aging population, I think we could be focusing more on the Irish community, on Irish culture and art, etc. Next, please. So maintaining mobility and function is really important in old age. And I know a number of organisations, a number of our Irish organisations actually do that. They provide a range of exercise classes. Some of them have walking groups. Some of them do walking football or walking other kinds of sport, and that's really important. But again, it's worth thinking about whether we can link with or host exercise programs run by the local authority, by a charity, or online. A dementia service I've done some work with in Basildon is not an Irish service, they linked with the local leisure centre, so that people who participate in their centre go 1 or 2 days a week to the local leisure centre. And they play adapted sport there, or they swim with coaches. So there are loads of things like that that may be possible if we think outside the box a little bit. It's about expanding our activities to increase mobility in general. I know a lot of the older generation, and sometimes myself included, we come in, we want to have a chat and a sit down and maybe have a cup of tea or something nice to eat. But maybe we should be doing more around encouraging people to walk, maybe memory walks, maybe doing some gardening. And, what about adapting set dancing or ceilidh dancing or something like that so that people can be more mobile? We should, if we can, link with local programs. Some of our organizations provide yoga. One or two of them Tai Chi, offer Tai Chi. And these are all very good resistance type of exercise. Falls reduction is really important, and many public health authorities, local authorities, and indeed health services will run classes for falls reduction, and that's really important for us. And why not do what we can to capture the significant expertise that we have in the Irish community? The dance schools, the dance teachers, the people who just love to dance, the exercise, the GAA, things like that. And emphasize the social and the cultural element of those as well. Individual exercise is really important, is really good, but the social element of meeting other people and dancing with them or playing, walking with them or playing football or whatever it is, really important. And we should be collaborating with sports facilities to provide adapted sport. And we have got links with the Irish Walking Football Association. I may not have got that name entirely right, but the meaning is there. So next slide, please. Frailty is something that is a major issue for older people, partly because COVID and lockdown have had a major impact on the most vulnerable people. And frailty is where the different body systems lose their ability to bounce back, even after quite minor events. You will probably know somebody who had a fall or a trip and maybe got a little bit bruised, maybe got, black face or something like that. But it knocks their confidence and they're not able to bounce back after that. So frailty is down to a loss of biological reserves, the failure of homeostasis. Homeostasis is the way in which our body systems regulate and get back to normal. And as we grow older, we have to work at keeping our body doing things like that. Frailty is also about a loss of muscle mass, which means a vulnerability to deterioration. So losing muscle means we can't walk faster. We often can't protect ourselves when we trip over something. We don't recover so easily from something like a stroke or a fracture, and it leads to adverse outcomes. So frailty increases the risk of immobility, falls, more likely to be admitted to hospital or to a care home. But also it increases the risk of, there's a whole list of things there: infection, delirium, incontinence, and medication harms and more. And frailty is more likely to occur if you live alone, if you have little social contact, or you live in a poor area. Because you tend to get forgotten. If you're not up to doing things yourself, you may not have somebody there to remind you or to encourage you. But we can do something about frailty, which is around making sure people stop smoking, they increase their physical activity, they need to do things around their diet, and I know I've got that on the next slide. But other things that are not as easy to manage are things like poor housing, cold homes, and isolation all increase the risk. So next slide. Preventing and reversing frailty. I think what's this frailty is bad news, but the good news is that it's reversible for the most part, and it's more reversible than disability. So the earlier you get it, the better. Generally, it's the role of the GP practice or primary care in consultation with the NHS to take the lead on that. But it's also important to address risk factors such as social contact, physical activity, and smoking, and managing multimorbidity and long-term illness and things like that, which impact on people. And it is reversible by including a program of exercise. Now, there are specific programs of exercise that are easy to manage, and it must include resistance training, the use of bands or weights or something like that. So it involves 30 to 45 minutes walking 3 or 4 times each week. So that's quite important. But exercise on its own isn't enough. We do need to look at people's diets and encourage them to have more protein. So protein intake should be higher than it is for the average person. And it's recommended that it's 1.2 grams per kilo body weight daily. And that's across all meals. So no good having a great big steak at tea time. You need to spread the protein. It's a very good program in Dublin by Travers and Dublin University. So it's worth looking at that. So frailty is a real issue, I think, in older people, but I've seen it as a real issue in the Irish community as well, in the older Irish community. And next slide. It's slightly different, this one, but I think it's quite important. It's about thinking of the future. And the research that Ellen did a few years ago showed that the majority of Irish people, like indeed many others, were worried about growing old, about being ill, about being immobile and independent. But by the same token, they didn't want to think about it or to discuss the future. So we do need to get them thinking about, or get us thinking about it. We do need to encourage wills and power of attorney. These are very important legal documents, both the property and finance and the health and welfare. We need to be thinking about things like that. But also there are practical things that we need to be doing. To prepare for a time when somebody might have an accident or a sudden illness, or they have to stop caring or whatever. So they're very simple things, but we've got to be careful about them. It's like, if I'm ill, how do I get access to my bank account? How does my daughter or my husband pay my energy bill? Do they know my GP, my dentist, my vet if I've got pets and things like that? What are the passwords to my account? No, I'm not suggesting people need to give away their passwords to everybody, but I think there are practical things. That means although I might have plenty of money in the bank, if I'm not able to access it, how do my family or the people who are looking after me access it? I think we need to begin to think about care. If there's a sudden illness or an accident and the family are unable to give the quality of care needed, and I say this a lot to family carers, well, who will look after the person you're caring for if you get run over by a bus tomorrow? And, it does happen. So practical things like that. And I think at a different level, we need to think about end of life care. Things like active treatment, do not attempt resuscitation orders and things like that. Now, I mean, I couldn't do it, but there are people who could do a whole session, they could do a whole course on things like that. But we do need to think about things like that. And funnily enough, despite our wish to think about the future, Irish people can be very good about funeral arrangements and where they want to be buried and whether they want to be cremated and things like that. So I think, we need to help people to think about planning for the future, not just the very end, but actually what happens in the meantime. So I think Irish community organisations do an excellent job. They do a really good job. And the Healthy Aging Project is not to undermine those in any way. It's actually to capitalise on the expertise and the motivation and the strength that already exists and maybe expand it, maybe make it more culturally defined than it is already. The will is there, the funding is there for the time being to do that. So all I can say at this point is good luck with the Healthy Aging Project. Gur míle maith agaibh.